friends, colleagues, now 7:30 Hong Kong time. We're going to start this COVID-19 crisis management and clinical experience in Asia. First of all, I must thank Broncos for providing this platform so we can share opinions among ourselves, within the region. I think actually this COVID-19 is changing the world. In the future, maybe this kind of webinar will be very popular to discuss different kind of issues and to save the etiquette. And today we have a few distinguished speakers to talk about their experience. All of them have worked in Wuhan for months. And still there's one doctor still working in Wuhan at the moment. And after that, I think many of the people are more interested in, other than into the topics, but to have a hot discussion on many unsolved questions. Today, the first speaker will be Professor Shiyue Li. Professor Shiyue Li is Deputy Director of Guangzhou Institute of Respiratory Health. He's a well-known bronchoscopist, respiratory physician, well-known in Asia Pacific and also globally. Today, he's going to talk about the COVID-19 control methods, and followed by Dr. Quang Li. Dr. Quang Li also does not really need introduction in Asia Pacific region. Currently, he is a director, Respiratory Medicine Center, Shanghai East Hospital, Chongqing University. He also worked in Wuhan for more than 1 month, and he is still quarantined himself in Shanghai at the moment. Still 8 more days to go before he can return to his usual job. Today, he's going to talk about imaging and diagnosis of COVID-19. And after that, Dr. Fengming Luo will talk about the treatment of COVID-19 patients. Dr. Fengming is the professor of the West China Hospital. He is the deputy director of the Department of Respiratory and also Critical Care Medicine. He stayed in Wuhan for 2 months and just finished his quarantine after back to Chengdu. And he's going to talk about the treatment of the COVID-19 patient. And after the 3 lectures, there'll be discussions moderated by Professor Chajed and by myself. Professor Chajed, I've known him for quite some time. Both of us joined the Asia Pacific Interventional Pulmonology Group. Currently, Dr. Chajed is the director of the Lung Care and Sleep Medicine, Mumbai, India. He's also the director of the Institute of Pulmonary Medical Research and Development, Mumbai. And he's very active. He has written a lot of papers. I hope being today's moderator, he will lead us into that in-depth discussion on this COVID-19. And welcome, Dr. Jamalu. You're early, not 10 minutes late.
Thanks, Prof. Big Lam. Okay. Nice to see you.
Without further ado, first of all, I'd like to invite Professor Shiyue Li to talk about the COVID-19 control methods. Professor Li, please.
Okay, thanks, Bin. Dear Asia colleagues, good evening. So I would like to No, not this one, sorry. Okay. Can you see the screen? Okay, sorry.
No, not yet. We can't see the PowerPoints.
Okay. Sorry. Okay. I found, sorry. Okay, let me see. Okay. Can you see the? Oh, no, see. Can
Not yet. Maybe
maybe
take
next speaker. I will try to fit something.
yeah. We just changed the order.
Okay.
But Professor Quang Li, if your video have some problem, can we see your PowerPoint? Yes, we can, right? Professor Quang Li, maybe you will be the first to talk about
Okay.
the imaging and diagnosis of COVID-19, please.
Okay. Now is fine for me. Now I'm okay.
Yes.
Yes.
Okay. So
We
can I begin?
go back to original order.
Okay.
Sorry.
Okay. So can I begin?
Yes, please.
Okay. So dear colleagues, good evening. So today my topic is measures for controlling COVID-19 in China. I would like to I will talking in these four aspects. First, I would like to talk something about the background. As we know, now this data is just update till to the 5th April. So we can see the total number confirmed cases worldwide is more than 1 million worldwide, and the daily new case we can see here still at the high level, almost every day 80,000 per day worldwide. So let's see the situation in Asia. Here's different country. We can see here the active cases and total confirmed and the total deaths. We can see here in Asia is still the situation is still very critical. And so talking about the possible transmission route for COVID-19, as we all know, the respiratory route is the most important route. But in my institute, we have isolated the infected virus from feces and urine of the patients first in the world. So apart in addition to the respiratory transmission, and maybe another possible transmission is the direct contact transmission, and also maybe another possible transmission may be the fecal or urine transmission. So as we know here, we can see here the respiratory transmission and the direct contact transmission, and also the infected people with the cough who wear the mask are also transmitted. And another possibility is the stool or urine transmission. So talking to the measures for the controlling COVID-19 in China, I think this is the four main measures. First, lockdown Wuhan on 23rd January. It's don't go to Wuhan, don't leave Wuhan. And the second measure is transparency. Real-time announcement of the numbers of the diagnosis suspected every day in every city nationwide. The third procedure is the measures is the inter-agency mechanism launched down to the community level early protection, distancing, early detection, early diagnosis, and early isolation. And another measure is wearing mask is required in public place. So we can see here the lockdown Wuhan on January 23rd, 2020. Here we can here the picture in Wuhan. We can see in the no one in the street. So let's see the after lockdown at the January 23rd, 2 weeks later, reaching the patient, the cases reached the peak, and 4 weeks later, the COVID-19 under basic control is we take the message here, lockdown Wuhan, and then 2 weeks later to the peak, and then to the 4 weeks later is under basic control. And this go as another measure is down to the community level. See here, we can every apartment entrance of the apartment should the temperature check and also wear the mask, and the early protection, social distancing, early detection, early diagnosis, and early isolation. This is published maybe several days ago. It was published by the one of the leading physicians for controlling COVID-19 in China, Dr. Chen Wang. He invented the Fengming Shelter Hospital. I think it's very important measure for responding to public health emergency. And another important measure, I think, is the masking is in public here, in the street, everyone wearing the mask. Let's talk about the personal protective equipment for the health workers. There are different equipment for the PPE, especially for the here's the health worker wearing the PPE and go to the go to the wall. And it's required for training the procedure for wearing the PPE for the every health workers. Also, the procedure for the takeoff of the PPE is requiring it is required for training. And also for the there's a guideline for using the personal protective equipment in dealing with the COVID-19 conducted by the National Health Commission. There's 3 different levels. Grade 1 is the standard protection, include the cap, mask, working clothes, and disposal latest gloves. And it's the general is applied applicable to the general medical activity. And also another grade 2 is enhanced protective, is including the disposal cap, as N95 mask, and another item like this. So here's the health worker wearing the grade 2 PPE to go to the consultant the patients. In another equipment is another level is grade 3 is additional protection. It's applicable to the high risk procedure like intubations, tracheotomy, and bronchoscopy lecture. So here's the grade 3 equipment, PPE. Here's the high pressure hook. And let's go to the some hard topic about the clinical application of the chloroquine. I think this is most hard topic. Here we can see it's data in China conducted by the Dr. Zhong, totally 179 cases. Let's go to the results. We can see here the day for reaching undetectable virus RNA. The treatment group was 3 days compared to the control group 9 days. So it's shorter time than the control group. And another topic is for the convalescent plasma, CP, now is preprint. Total take case include. So we can see here the laboratory parameters. Here we can see after receive the CP, this index was improved, and they see the serum RNA test up from after receive the CP 2 to 5 days later, the virus RNA was negative after 2 to 5 days. And here's the pictures. So last, I would like to acknowledge of my mentor, Dr. Professor Zhong. He's one of the leading physicians for controlling COVID-19 in China, and all the colleagues in my hospital and in my institute. Also, thanks for Dr. Luo. He gave me some PPTs, and everyone who is fighting against against this public crisis. Okay, thank you. Thank you.
Thank you, Professor Li. Thank you very much. And we will leave the Q&A session later. Now followed will be Professor Quang Li. He's going to talk about imaging and diagnosis of COVID-19, because there's a lot of people talking about the nucleic acid test may not be that sensitive, and at one point in China, people are proposing maybe using CT is more sensitive, but maybe it's less specific. Let's see. Dr. Quang Li.
Hello everyone, I'm Dr. Li Qiang from Respiratory Medicine Center, Shanghai East Hospital, Tongji University. I would like to spend some time with you today to discuss the following 4 questions, and the 4th is our focus today. This was the global prevalence of COVID-19 2 weeks ago. We saw that there were 430,000 cases in the world at that time, and China was the largest, more than 81,000 cases. But now, with the control of the epidemic, the number of cases in China is not growing that fast. So now many countries have surpassed China. For example, the United States now has the world's largest number of cases. The number of cases worldwide may now exceed 1.1 million. There are many cases in Europe, such as Italy and Spain as well. The pathogen of COVID-19, named SARS-CoV-2 by the WHO, belongs to the Coronaviridae family, beta coronavirus genus, which binds to the ACE2 protein on the cell surface and then enter the respiratory epithelial cells. At the same time, it can consume some T lymphocytes and destroy the human immune system. As for the epidemiological characteristics of COVID-19, its reproduction number is about 3.77. Initially said that it was about 2.1. Now it may be 3.77. The main source of infection is infected persons. In addition, it is not particularly clear whether a symptomatic infection can be considered as the source of infection. So now we are also highly concerned about asymptomatic infection in China, and they are isolated and observed as patients. At present, the transmission route is still considered to be droplet transmission, and also close contact is also the main way to cause transmission. The transmission of body fluid and aerosols is only possible in some specific environments, such as doing various medical operations or in the relatively close environments. The population is generally susceptible. In the early days, we thought that children are not susceptible, but in fact, now all people are susceptible. The incubation period is generally considered to be 5 days, and the longest can also be up to 27 days. The second part is about the clinical manifestations of COVID-19. The common symptoms of COVID-19 are similar to those of common respiratory tract infection, such as fever, fatigue, dry cough, chest tightness, and shortness of breath. It is different from our common upper respiratory tract infection, including influenza and common cold, which has lighter symptoms of catarrh in the upper respiratory tract. The symptoms of nasal congestion and a runny nose are less. Most patients have mild symptoms in the early stage of the disease and recover after a week. The prognosis of most patients is good. About 60 or 70% of the patients in China may recover very well, and some even have only a few days of discomfort and soon recover after rest. However, a small number of patients can develop more severe symptoms after a week, such as dyspnea, and in severe cases, patients can quickly progress to AIDS, including septic shock, and then some metabolic acidosis and coagulation disorders, and patients who do not receive timely treatment will die soon. That is why now in many countries the mortality rate is still very high, such as Italy about 10%, Spain is close to 10%. Now the diagnosis of COVID-19 is mainly by RT-PCR. We usually take nasopharyngeal swab samples. However, if the specimen is not taken with standard procedure, then its positive rate is only 30% to 40%. So we should be very clear about this. Second, we can do some tests for antibodies, which can only be done qualitatively in China at the beginning. As long as IgM and IgG tested positive, this patient may be diagnosed as COVID-19 patient. But in the later stage, IgM and IgG can be measured quantitatively. This is also an important means for us to diagnose COVID-19. We also have some clinicians had suggested to introduce chest imaging method to diagnose, as nucleic acid and antibody test capacity is insufficient. Now I will talk about COVID-19 patients' imaging findings and the mechanism of information. China National Health Commission has released a guideline for COVID-19 diagnosis and treatment. It says, in the early stage, there were multiple small patches and stromal changes in both lungs, especially in peripheral parts of lung. Then it's developed into two multiple ground glass opacity and infiltrating shadow. In severe cases, lung consolidation may occur, and the pleural effusion is rare. In China, radiologists have divided the patient into 4 stages: early stage, progressing stage, critical stage, and recovery stage. However, in our clinical experience, we have observed normally 3 stages. First is early stage. We can see some lesions in peripheral part of lung. If patients were not timely treated, they might fall into progressing stage. In this stage, around 85% of them will become mild or moderate. They normally have a short progressing stage and then quickly move to recovery stage. The rest, 15%, mostly are aged, immunocompromised, including diabetes, transplantation, or hepatitis, will go to severe or critical stage. They normally have a long progressing stage and pretty severe lung fibrosis. In early stage, lesions are regional or patch shadow-like, usually found in segmental or subsegmental level in outer 1/3 of lung and close to pleural. Single or multiple GGO could be observed, some with presence of septal thickening, in which air bronchogram and or enlargement of vessel might be observed. Let's see some classic CTs. We can see some GGOs in early stage for this patient. Comparing other infection, including flu, it's a bit different. In early stage, if nucleic acid is not available, if patient developed fever, it might be positive. It's suggested to be quarantined and treated. In all 3 GGOs, we can see vascular enlargement and they are all close to pleural. During the epidemic, if patient develop fever, cough, reduction of lymphocyte and multiple GGOs in peripheral lung, very high chance it's a positive COVID-19. We can see clearly septal thickening and air bronchogram in the patient, as well as vascular enlargement in this patient. This patient is showing network-like vascular enlargement. To understand the cause of the imaging finding, we might need to understand the pathology behind. In China, some physician has done ttNA to get tissue sample. Histology shows diffuse alveoli damage, which is mainly due to virus. It comes with diffuse alveolar injury with myxoid exudate. The inflammatory infiltration of mononuclear cells are noted, mainly lymphocytes, in the interstitium of both lungs. In the alveolar cavity, there are multinuclear giant cells of the pleomorphic inclusion, accompanied by atypical and enlarged alveolar epithelial cells, and the prominent nucleoli presenting with the changes of viral cell disease. No obvious intracytoplasmic or nuclear virus inclusion bodies were found. This is what I can see for early stage patient. Many clinicians will ask why many of its lesions are located in subpleural area and the peripheral parts of lung. As we know, the COVID-19 has some coronal protrusions, and the envelope of this protrusion contains S protein. The S protein can bind to S2 on human mucosal epithelium. Recently, a research team in the United States has used cryo-electron microscopy to analyze the structure of the COVID-19. Also, they analyzed the affinity between S protein and ACE2 using the surface plasma resonance technology. It was found that the affinity of the COVID-19 and ACE2 is 10 to 20 times higher than that of a SARS virus. This explains why the COVID-19 is so contagious. There are also some studies have shown that ACE2 protein is widely distributed in the epithelial cells of the respiratory tract mucosa, as well as the endothelial cells of blood vessels and other mucosal epithelial cell surfaces. About 64% of ACE2 is distributed on type 2 alveolar epithelial cells in the lungs, in which type 2 alveoli are generally distal. Through the above evidence, we can understand why many of its lesions are located in the subpleural area and the peripheral part of lung. When disease advances to the progressing stage, the lesion increase and enlarge in CT images. The lesion mostly appear in multiple lung lobes, mainly in the lower lobes. Also, the lesion will become dense and the boundary will be unclear. There can be some ground glass opacity around solid nodules. We call it halocyle. The other part of the imaging is manifested as an anti-halocyle. That is, it has some shadows of increased density around the periphery of the lesion. Then the interlobular space around the lesion can be thickened due to interstitial edema, and a crazy paving appears overlapping on the GGO. In the progressing stage, some mild or moderate patients' lesions will increase. Consolidation may occur in some areas, and some areas may show proliferative changes. However, the range of lesion in this patient is really greater than 1/3 of the total lung volume, which means their lesions are more limited. We can see that this is the lesion progression 5 days after the onset of the disease. By the 8th day, he had a CT scan from re-examination. We can see that the range of the lesion is obviously expanded. Also, there are some consolidation or some proliferative lesion in this area. We can also see the shadow of some new blood vessels, but its pathological range change is limited in both lower lobes. Therefore, chest tightness and dyspnea symptoms are not obvious in such patient. This is a 48-year-old male, and he is a moderate patient. A week after the onset of the disease, the range of the lesion has expanded compared with the earlier onset. We can see the lesion in both upper lobes and both lower lobes, but his disease is still relatively limited, not more than 1/3 of the whole lung, so the patient's breathing can be maintained. This is a 56-year-old male patient, and he is also a moderate patient. After 10 days of onset, we saw that his lesions were in both lower lobes, but the range of his disease is still relatively limited. There are about 15% of patients, mainly in some older age people, which has basic diseases such as diabetes, hypertension, coronary heart disease, and some hepatitis. Such patients often rapidly progress. The range of disease significantly enlarged. Diffuse lesion was seen in both lungs. Here we can see a 56-year-old male, 8 days after the onset of the disease, had obvious ground glass opacity in both upper and lower lungs. The patient felt chest tightness and difficulty in breathing. In progressing stage of critically ill patient, thickening of the oblique fissure and the patchy ground glass effusion may be seen. Then the range of the ground glass exudate is relatively wide. Such patients will have significant difficulty breathing, and some patients will be given oxygen therapy. If such patients do not receive timely oxygen treatment, they may suffer from lack of oxygen and other complications. In the earlier days of the outbreak in Wuhan, many of these patients died outside the hospital because they did not reach the hospital in time. In addition, we can also see the shadow of some blood vessels and a small amount of pleural effusion. Air bronchogram may also form. This is also an advanced severe patient, a 70-year-old male whose lesion is very diffuse on imaging, and the patient needs oxygen therapy to maintain normal oxygenation. This is a 74-year-old female patient. She is an obese patient. In China, COVID-19 has a feature. Many young patients who develop severe or critical illness often are accompanied by obesity. So obesity is also an independent risk factor for aggravation of the disease. This patient also needs to uptake oxygen to maintain oxygen saturation in the normal range. This is a 65-year-old male. He is a severe patient. This patient requires non-invasive mechanical ventilation to maintain oxygenation in the hospital. If there is further progress, it is likely that this patient will need intubation. In the early stage, our Chinese clinicians were more cautious about intubation and found that if many patients did not intubate in time, the patient might die in the process. So in the later stage of our epidemic, our doctors in critical illness all advocate that we should be more active in endotracheal intubation and ECMO for these patients, which is more active than what we usually use in clinical practice. So in the later stage of patients like this, we usually give them earlier endotracheal intubation. Then, what's the pathological basis of severe and critical type of COVID-19? Combined with some results of our later autopsy, we can see that in this severe patient, there are a lot of fractures in the alveolar wall. In addition, a lot of bleeding in the alveoli, and a widespread deposition of fibrinoid exudates. In the alveolar cavity, we can see the expansion of capillaries and the rupture of the thickened parts of the alveolar septum. With special staining, we can see that in addition to bleeding in the alveolar space, part of the alveolar wall is broken, and it can be fused into a large hematoma. At the same time, we can also see by special staining that in the alveolar space, in addition to a large number of red blood cells, there are damaged type 2 alveolar epithelium cells, macrophage, and histocytes mixed together to form a clear cell plug. We can see that there are a lot of cell plugs in the alveoli. So in the process of treatment, even if you give him a ventilator, the oxygen saturation cannot be effectively improved. So this is a very important reason for the death of this kind of patient. Secondly, we can see the dilation of capillaries in the hemorrhagic focus and the infiltration of lymphocytes, plasma cells, macrophage, and histocytes in the alveolar septa, which thickens the alveolar septa. After the advanced stage, the majority of patients with mild and common type recover quickly. The changes in the treatment of light patients are relatively fast, and CT and the clinical manifestations are closely related to the clinical condition. Some patients, after receive antivirus and anti-inflammatory treatment, including Chinese medicine treatment, they have also received very good results. Both the range and the density of the lesion are reduced. During the absorption process of the lesion, it presents some irregular strip-like shadow. And the partial alignment can be completely absorbed. The degree of bronchial thickening can also be reduced. This is a 58-year-old male. A, B, C, D 4 pictures represent the 3rd, 8th, 11th, and the 17th days of onset, respectively. On the 3rd day, there are patchy and some ground glass changes on both lungs. By the 8th day, we saw a slight expansion of the lesion, but some lesions had begun to absorb, such as the left upper lung lesion had been absorbed. By the 11th day, we can see that the left upper lung lesion is still absorbed, and the right upper lung lesion is also gradually absorbed. But the 17th day, the lesion were basically absorbed and clean. Therefore, we can see that the absorption of lesion in most common patients is relatively fast. This is a 46-year-old female. We can see that there was some scattered lesion in both upper lungs at 7 days after onset, and there are still some lesions in the left lower lung. By the 12th day, we can see that the lesion in the right upper lung began to be obviously absorbed. The left upper lung lesion was also absorbed, and the left lower lung lesion was obviously absorbed, leaving behind some microstrip shadows. This is a 39-year-old woman who had been ill for a week, and then we saw some ground glass effusion under the pleura on February 28. By March 6, we saw that her lesion were almost absorbed, so most of the patients with common type or mild disease have almost absorbed the lesion in 2 weeks. It takes longer time for around 1 to 2 months. During the process of absorption of lesions, new lesions will occur in parts of the patients. This is what we call lesion mobility in clinical. If doctors are not in front line to manage patients, they may not be aware of this problem. We are also in process of patient management to find out this problem. Few patients may experience extensive fibrosis remaining in the lungs. This is a 69-year-old female patient. She is a severe patient. After 25 days since the onset of her symptoms, the absorption of lesions are not optimistic. A lot of lesions were left. This is a 66-year-old female patient. Onset of symptoms started on 26th of December in 2019 until 14th of March in 2020. Many lesions are left along the days and are not absorbed. On 20th of March, part of the lesions in right upper lobe were absorbed, but still left a lot of lesions. The absorption of lesions can be very slow in severe patients. Part of the patients may gain new lesion during the absorption of old lesion. It is similar to so-called mobility in clinical. This is a renal transplant patient using immunosuppressive. After 1 month of symptoms onset, on 27th of February, we observed a large area of lesions in her right lower lobe and some in left upper lobe. Until 17th of March, 2 months and 5 days since the onset of symptoms, new lesions were found in right upper lobe which didn't have lesion before. Some lesions were found in left upper lobe as well. However, lesions in right lower lobe were absorbed. What's the reason of the changes in radiology? The occurrence of such mobility may be a kind of immunity inflammation in the lungs. The exact mechanism remains to be further studied and elucidated. A small number of patients may be left with extensive fibrous lesions at the later stages of the disease. This is a 70-year-old female patient. 2 months after the onset of symptoms, she went into recovery period. However, extensive fibrosis occurred in her lungs. This is a 64-year-old male patient. He also got extensive fibrosis after 2 months. He requires oxygen inhalation. Otherwise, he may experience lack of oxygen. At the beginning of the outbreak, when the test and the antibody test cannot satisfy clinical needs, clinicians combined infection control laboratory, clinical symptoms, and chest imaging to do diagnosis for most of the patients. We hope that the outbreak of virus in all countries can be passed as soon as possible, especially for those experiencing serious situations. As a clinician, we must have confidence and strong will. We believe that we will overcome this. Thank you very much.
Thank you, Professor Quang Li, for the excellent talk. And the next speaker will be Professor Luo Fengming. He's going to talk about treatment of COVID-19 patients. Professor Luo, please.
Okay. Hello, everyone. I'm Fengming Luo from BSH Hospital, and I want to talk about the treatment of COVID-19, especially about severe and critical. And at first, we should know what kind of types of COVID-19 is severe. Severe syndrome include shortness of breath and respiration rate greater than 30 times per minute. Oxygen saturation less than 93 at rest without oxygen. And oxygen index is less than 300, and also significant lesion progression within 24 to 48 hours on CT scan. Also, the CT scan is very important. And also critical syndrome type is just like the pneumonia and the respiratory failure and the mechanic ventilation and also shock, or combined with other organs function failure and need to be monitored and treated in ICU. So every criteria can be made, and we can make the diagnosis for the severe critical care, a critical condition. And we put severe and critical types are also referred to as severe syndrome type of the COVID-19 in China. And it's the epidemiology about the COVID-19, just like Professor Li said, that it's all over the world. And it's very important to identify the critical clinical warning indicators. And it's, for example, the lymphocyte count decreased progressively, and the IL-6, CRP, and the dimer increased significantly, and also lactic acid is progressively increased. With severe basic disease such as diabetes, COPD, and hypertension, and chronic kidney diseases. And also CT show lung progress rapidly before and after comparison. For example, imagine lesion range more than 4.5, and the high fever continued for 10 days, and also older age, and also the respiratory distress, and the breath rate increased significantly. And Professor Li just talked about pathological changes. I also just want to say that there's inflammation and also mucus over there in the lung, and also some vascularitis over there. We should pay attention to it. And the mechanism of the disease, we also know about the various infections, so I don't want to talk more. And the clinical characteristics is that progress or low fever occur after the acute fever phase, and dyspnea or hypoxemia mostly, and develop rapidly into respiratory distress syndrome. It's maybe 1 or 2 days, and it's very fast. So, sometimes shock and metabolic acidosis. Sorry for that. And it's the CT image just like this one, like Professor Li said that it's why somebody always mute me? And it's like the city recovered. And so the treatment principle is that the should prevent the complication and treat the basic diseases and prevent the secondary infection and support the organs. It's very important that the sufficient respiratory support at the early stage to reduce tissue and organ hypoxia. And at first, should the respiratory support, we should remind respiratory rate less than 30 times per minute. Oxygen saturation should be more than 95. Patient without obvious respiratory distress. Also, we should monitor the patient, this vital signs of the patient, and if the non-invasive mechanical ventilation or high flow, and sometimes if 2 or 6 hours improve, the patient does not improve, we should be maybe the intubation should be applied to the patient. And we also find that prone position is very important. Ask the patient to lie prone or lateral position at least 4 hours per day. If the patient was is sedation, maybe 12 hours every day. It's very important, not only for the severe patient. They also help to stop the progress of the middle or moderate patient to progress into severe or critical patient condition. And the other supplement is non-invasive or high flow. The effect of these types of transient oxygen therapy need to be closely observed. That's the change to invasive mechanical ventilation within 2 or 6 hours if the situation does not improve. And the standard for invasive ventilation is that of patient with less than 150 oxygen index perform the treatment of during the treatment of invasive non-invasive mechanic ventilation, which the intubation maybe as early as possible. But sometimes if we can try the large dosage of the steroid, maybe you can try to know if it improved or not. And some antivirus medicine, including interferon and ribavirin, Abidol, Kaletra, and also chloroquine. Chloroquine we used maybe a false fatal, but some in US and use also hydrogen chloroquine. And we should monitoring the adverse drug reaction, but for example, liver function injury, myocardial injury, or some other side effect. We should always monitor the side effect of this patient. Maybe you should take the test of the blood maybe 3 or 5 days. And as to the antibiotic, avoid blind or inappropriate use of antibiotic. If there is no sign of a bacteria or fungal infection, no antibiotic for this kind of patient. if you can ask the color of the sputum of the patient, if they change to yellow and purulent, maybe you can use antibiotic. Sometimes we can do the sputum culture for the patient and select the antibiotic for the patient. Anti-inflammation in the guideline in China, it's not recommended for light or normal types and large doses. Dosage of the steroids are not recommended. And maybe we also tried in some patients use the large dosage of the steroid. For example, we have a 13 very severe critical patients. We use the methylprednisone for 125 milligram every day, twice daily, and maybe sometimes some patients we use the 250 milligram twice daily. Some very critical patients improved after the treatment. But if the patient the situation is very good, it's very stable, maybe low steroid for this kind of middle and moderate patients for steroid. And I don't think just for example 40 milligram methylprednisone is useful for this kind of patient. Sometimes we use this dosage of the patient, but the patient still progress in critical condition. And also some other indicator for use the steroid. In severe ELS cases, the difficult to breathe increase progressively. Also, sometimes the CT image progress rapidly. For example, within 2 or 3 days, the CT lesion increased 1/3 or half. We should maybe short time use of the steroid. And according to the guideline, it's 1 to 2 milligram kilogram every day. But I use maybe double or 4 times with this dosage for the very, very critical patient, especially in the patient without the intubation. And also anticoagulant. We should evaluate the bleeding risk, and we can use the low limb vein thrombosis screening, and we use the low molecular weight heparin prevent the anticoagulation for the patient. And some other medicine, for example, antioxidation and NAC for the patient. Some doctors like to use the traditional Chinese medicine and sometimes regulation of the intestinal flora, but it should be investigated for give more evidence for us. And also some new strategy, for example, just talk about the plasma from the recovery patient, and also anti-IL-6 antibody. This is for the patient with high IL-6 concentration, and also extensive double lung lesion, very severe and in severe critical patient. And we use maybe 400 milligram with the saline. Patient with infection and others condition cannot be used this treatment. And also ECMO and circulation support, and also CRT and nutrition support is very important sometimes in some cases. But in some, especially in the epicentral, maybe it's not available for all patients. So it's very difficult for us to make a decision which patient we should use this kind of treatment for them. So especially in very if there's a lot of critical patients over there, and also respiratory rehabilitation for the patient. We should, after discharge from the hospital, we should give advice for the patient to recover soon. And to the standard of the discharge, we should have the patient normal body temperature for over 3 days, and the patient's syndrome improved. Lung immunology improved obviously, and nucleic acid is negative twice between 2 days, and AGM decrease, AGG increase, and we should advise the patient isolation at this place after discharge from the hospital. And as to the IgM and the IgG, sometimes the patient, the IgM may be negative, maybe IgG still negative for some patients, but the nucleic acid is still negative for the patient. So we also discharge the patient from the hospital. And there's some cases, for example, we use the steroid for 40 milligram twice daily, and also use the prone position for the patient, and with high flow, and the patient recovered. And the other patient maybe use the prednisolone for 80 milligram twice daily, and within a short time with high flow and also antivirus medicine, and this patient also recovered from the treatment soon. And it's the CT scan, and also the male patient, and this is the treatment for them. It's only use the non-invasive ventilator, and also use the prednisone, and we just use at the beginning with only 40 milligram, and the patient still progress, so we increase the dosage to 120 twice daily. After the intubation, the patient improved and recovered from the disease, and discharged from the hospital. It's very successful for the patient. It's the X-ray for the patient, and it's the other case, and recovered very good. So it's very important to make early detection, early intervention, and reduce the risk of progression to severe disease. If the patient progresses in very critical conditions, it's very difficult for us to treat this kind of patient. That's all. Thank you, everybody.
Thank you, Professor Luo, for the excellent talk. Now we pass to Professor Chajet to lead the discussion and Q&A session.
Great. I think we've had excellent 3 speeches with a lot of experience, a lot of clarity as far as the diagnosis is concerned, and as well as the course of the patients are concerned. And we had a lot of case presentations, a lot of radiological examples, and also the treatment experience. So now to join us in the panel discussion, we also have with us Dr. Jamalul Azizi, who is the head of respiratory medicine at Serdang Hospital, Kajang in Malaysia. We also have with us Dr. Ling Sang, who is from the Department of Critical Care Medicine at the Guangzhou Institute of Respiratory Health, the first affiliated hospital of Guangzhou Medical University. We also have with us from Philippines, Dr. Ronald Fajado, who's a very active interventional pulmonologist from the University of Santo Tomas, Philippines. We also have with us a colleague from India, Dr. Harikishan Gunugunkla, who is a very active interventional pulmonologist from Yashoda Hospitals in Hyderabad. And we also have with us Dr. Titiwat Sriprasad from Thailand, who is from the Chulalongkorn Hospital, Thailand, and he specializes in pulmonary and critical care medicine. So now what I'm going to do is we've got some set of questions which have already come up to us, and we've compiled them into a PowerPoint presentation. And of course, we can also have these lectures. I mean, if there are any questions from the, from the panelists, we can also take them. So I'm just going to share the presentation now. Just give me a minute, please. Yeah, so is the presentation seen?
Yes, we can see.
Awesome, awesome. Okay, so the first, the question that has come up is related to the diagnosis, and the question which is being asked is about experience with testing by point of care tests. So, are there any tests which have been approved and used also by the panelist as a point of care tests?
Okay. The first, very fast test is that detect the antibody in the blood, IgG and IgM. Is very fast, maybe within several minutes. But as the golden standard for the test is the nucleic acid for the virus, and we should collect the samples and test the samples within 4 hours, because the degeneration of the RNA of the virus is
I think the question has come because sometimes the RT-PCR can take time, and maybe the point of contact, the point of care testing could reduce the turnaround time and help us to diagnose the patients early. So is anybody on the panel using any point of care test already, or are we still waiting for them? Okay, so that seems to be the case. So I think, if I understand correctly, the point of care tests are still in the development, and I think, as rightly pointed out, the RT-PCR is the gold standard at the moment. This is the next question which has come up. How much biochemical markers, just CRP, ferritin, D-dimer, and serum LDH, are useful in the management in patients with clinical and radiological suspicion of COVID-19 when the RT-PCR is nasopharyngeal swab negative? I think this question has come up, and it was also discussed earlier by Dr. Quang Li, that if the nasopharyngeal swab is not collected properly, then there is a risk of the sensitivity going down. And also Dr. Shiyue Li also discussed the same. And the sensitivity could come to 40 to 60%. So what are the suggestions? I think this is a very varied question, because this is a question which is often discussed in India as well. So I would really appreciate if the panel could comment on this.
I think it's very important to ask the history of the patient and also symptom of the patient, and together with the CT scan, maybe sometimes you can follow up the CT lesions, and if the CT images changed very fast, maybe based on all these kind of things, you can make a diagnosis at the same time. But sometimes my suggestion is that more and more times for the for the test is very important.
Yeah, okay.
And
so Dr. Shiyue Li or Dr. Yes? Yes, please go ahead.
I think sometimes I have a patient. We have maybe 6 times of the nucleic acid test, but still negative. And we test the antibody IgM. At the beginning, it's negative, and then weak positive, and then positive, and then IgG increased. So we also make the diagnosis for the patient with COVID-19.
Okay.
I think at the moment this question may not be that important because we have no specific treatment for the COVID-19. Until we have a specific treatment and early diagnosis to treat accordingly makes it more meaningful. Currently, probably if you have such kind of patient, you may just consider this as a COVID-19 patient, isolated patient, etc.
Yes.
Mm-hmm. Excellent. Okay. So I think that's an important point which is already made, that if the RT-PCR swab is negative, based on the clinical history and other parameters, continue to treat them as a potential COVID-19, and then as time goes ahead, one can also do the blood test and try to get a supportive diagnosis.
Yeah.
Okay. So we move to the next slide. So that's the treatment part. The question is, and also discussed very often in the Indian circles, is about hydroxychloroquine prophylaxis. In China, in Hong Kong, has this been, or in any parts of Asia, is there experience with the hydroxychloroquine prophylaxis?
Yes, I like talking something that based on our clinical trial is the open the open trial. It seems he can sorter the virus DNA negative time, but it seems to behave for the patients. But this is just for the limit cases, and also it's not the open. It's not the control study. So I think now that we have the limit information for this.
Yeah, so at the moment in India, there is a recommendation, a guideline that the healthcare workers who are working with the COVID-19 patients can also take prophylaxis. So are there any similar recommendations in any of the hospitals where the panelists are there?
No, I don't think this medicine is permitted for prevention. It's just for the treatment of the patient. I think it's very important to use the personal protective equipment, just like Professor Li said, that we have 42,000 doctors and nurses work in Wuhan. Nobody infected by the virus after almost 2 months work over there, as reported by the government. So I think the personal protective equipment is the most important things for us to protect us to infection. Okay.
And actually, in our previous webinar with the European colleagues in UK, they are running a study to give hydroxychloroquine to patients with mild disease as they are still isolating themselves at home. The study endpoint to see how much will progress severe disease compared to those without taking the hydroxychloroquine, but not as a prophylaxis.
Not as prophylaxis.
Worker. No, there's no good evidence.
No.
So it seems that it's only in India at the moment where the HCQS, that is the hydroxychloroquine, is being recommended for prophylaxis, and it is basically for 8 weeks. So it's once a week. So I think the message is very clear from our colleagues that, and very interesting experience from Wuhan, that the PPE is one of the most important factors which will help in prevention, and I think that message is very strong and reinforcing that the PP is most important. Now we move on to the next question is about role of interferon alpha 2b in COVID-19. This is a question which is being asked, and I'm not aware of any data as far as the interferon alpha 2b in COVID-19 is there. Does any of the panelists have any information about this, any experience about this?
I can share some experience for this medicine. We use this medicine for liberalizing according to the guideline in China. And in fact, some patients still progress in critical condition. So we don't have the data compare use or without this medicine. So it's hard to say it's effective or have low effective with this kind of patient. But we have some data set that if the patient always have the positive test of the nucleic acid, for example, some patient maybe within 1 month or maybe 40 days, especially in patients in the diabetes, the nucleic acid always positive for us. So no discharge from our hospital. To this kind of patient, we injection the interferon for this kind of patient, maybe faster the negative of the patient. Yeah.
Okay. Okay. So thank you very much. I think we move on to the next question. And I think the experience, is there any experience with the combination of hydroxychloroquine and azithromycin? My question would be, this data about the hydroxychloroquine and azithromycin has started on coming, more and more discussion in the last few weeks. So is there any experience already in China about, or other parts, where the panelists are working about hydroxychloroquine and azithromycin? I know there was a data which already was shown by Dr. Shiyue Li that the conversion is better when it is when hydroxychloroquine is used. But what about the combination with azithromycin? Is there any benefit?
No,
So far, we are not had the combination of the hydroxychloroquine and the azithromycin. So we haven't used this combination.
Okay.
No, I don't have.
Yeah, can I say something? Yeah, in Malaysia, our practice is mono. We use chloroquine or hydroxychloroquine. We don't use combo using.
So you don't use combo, is it?
No, we don't use combo.
No. So anybody else in the panel which is using azithromycin? Any experience with azithromycin?
So we actually use combined hydroxychloroquine and azithromycin instead of antiretroviral drug. And so we have the study running comparing the efficacy of this combination compared to the hydroxychloroquine and antiretroviral drugs. So we want to compare this, but we are running the study. Based on my experience so far, it's used for the moderate pneumonia, but when it comes to severe pneumonia, this combination is not enough for treatment.
Okay, so the question, the point which is being also discussed is that this combination, in addition to help with the pneumonia, might be helping with the COVID-19 also. So does the panel believe that this combination can be given in mild to moderate? Is that what is happening in Thailand? Is it being routinely given?
It's actually not routinely because the guideline still the guideline is not like the definite, but it's optional. But in the guidelines for the government, in the government guidelines, that we can use this combination as a choice of treatment.
Okay. Yeah. Hari Kishan, are you using this in Hyderabad, in India? You're muted. You're muted. You need to unmute.
Yeah, hi, Prashant.
Hi.
We have 2 patients in our hospital now. one patient is very mild. He's maintaining room air saturation, so he's getting only hydroxychloroquine. One patient is still spiking fever on day 8. So we have combined hydroxychloroquine with azithromycin for him. Still the fever spikes are not coming down. So that is the case we were discussing with Dr. Fengming Luo today. But I don't think there is any evidence here.
Not evidence. Okay, okay. So if there is no further, sorry, where is the evidence? Yeah. So I think if there is no, just a moment, my screen is a little bit, 1 second. Sorry, the screen is not showing up. Can my screen be seen? Is it? Yeah. Sorry, I can't see. 1 second.
Half of the screen can be seen.
Yeah. Just a Lam, sorry about that. Not sure why it is. Sorry. So I think that was the last question from my side. And now I will hand over to Dr. Bing Lam, who will take over the second part of the discussion.
Okay, thank you. Now let's go to the second part of the discussion. Show me the slide, please. And yes. Page down. Okay, this is regarding to the policy making, prediction, and transmission features. So what are positive and negative factors which will inhibit the growth of coronavirus in India? Anyone from the India government are going to answer this question. So, well, yes, any colleagues from India can say, what do you think are the positive and negative factors which might affect the coronavirus condition in India?
So Hari, you want to take this and then I can add on my comments?
Yeah, the positive factors, what I think is we are early into lockdown. We announced lockdown quite early than the European and American government. So that is one positive factor. The negative factor would be like we don't have this IT and IgG as of now available in all parts of the country. So cleaning a parts operation is still becoming difficult, and designated coronavirus hospitals are yet to come. So all the patients gets pulled up in the community, all the community acquired pneumonias, they go to hospitals. You don't know which is positive, which is negative. And the PCR is taking around 24 to 48 hours. So these are the negative factors right now that might inhibit, that might increase the cases in India.
Yeah. So from my side, I think the positive factors, like Hari pointed out very clear, very correctly, is that we went into a national lockdown quite early, and we are now onto almost day 12 of the national lockdown. We've now crossed around 4,000 cases. So this is the positive thing. What has been happening positively is, like Hari said, initially we were having the hospital, certain hospitals where a part of the hospital is being dedicated to COVID. Now what is happening in Mumbai is now there are hospitals which are now designated as COVID hospitals. So the idea is to segregate the people, the patients to the COVID hospitals, and try to get and have the non-COVID and COVID separate. So this is a little bit of the positive things that we are, this lockdown is also giving us, buying us time to put on strategies in place. The negative factors, of course, is it's a large country. We need to get more testing done, and the population density is very high. But the measures, at least what I've been taking in Mumbai, is this containment. So areas, hotspots are being defined for the city, and if a hotspot is identified, that area is going under containment. So in Mumbai, if I go back to yesterday's data, or Saturday evening, we had 191 containment areas. That means already the city is in a lockdown, and these 191 areas are under a higher level of restriction. So I think these are the factors, hopefully, which will help us in controlling the virus. And of course, increased testing, the point of care test, if they come in, I think that will allow for a much earlier diagnosis so that the positive people can be contained. I think these are the factors. Yeah.
So how many tests are being done on daily basis? Do you think once a point of care test is available, a quick test, expect the number of cases to increase tremendously?
I mean, that is what one would, if one believes this theory that the number of cases are less because less testing is happening, and if that is the case, yes, the number of cases will increase. But on the other hand, fortunately, we are still not seeing the clusters. Therefore, we are being optimistic that the number of cases which are there in the community, which are being missed, is not in large numbers. But nevertheless, I think more testing will give us a more transparent and a more clearer picture.
Thank you.
It's very important to separate the health people with the patient. So the test for the virus is very, very important. I think positive for the India is that somebody said that the temperature is helpful to inhibit the growth of the virus. But maybe we don't know. It's my opinion. Okay.
Yeah. It's just being a bit more optimistic and wishful thinking. But of course, we shouldn't take it for granted.
Yeah.
I guess the second question will be how is India government doing in comparison to other countries? But if India starts quite early, that's pretty good actually.
Yeah.
Okay.
Yeah, I think we strongly believe in the strategies which the government has implemented, and I think we are very confident that the steps which the Indian government has taken for the containment of the virus were taken at the right moment, and we really hope that the steps which are being taken will give us the benefits.
Yes, I think it's actually to suggest healthcare workers to consider hydroxychloroquine prophylaxis, which may also turn out to be a good study project to see whether or not.
Yes, absolutely. I think the point is, I think Dr. Lam, you brought up this point very well. I think India is the only country where the healthcare workers have been, are being given the possibility of taking hydroxychloroquine prophylaxis, and it's for 8 weeks. And although we don't have a lot of data as far as that is concerned, but there's a lot of supportive data if you read the literature, and hopefully I think that along with the lockdown strategies, maintaining the distance strategies, and one of the droplet infection strategies will help us to reduce the risk of infections. But also what Dr. Lee Chang said, I think it's very important that if the proper PPE is also used, I think that also reduces the risk of transmission to the healthcare workers. And the one thing one would worry is that if somebody is taking prophylaxis, it should not make that person a bit complacent towards the use of PPE.
Can I ask Dr. Harry one question?
Yes.
Social distancing in India, how do you do it? I mean, given that India is a huge country, huge population, I'm just curious, how do you practice social distancing?
Yeah, like our Prime Minister has come too early. He encourages the population to do social distancing, and all the hospitals are also like having boards how to maintain social distancing. Now all the WhatsApp groups are like full of information on how to do this social distancing. That is being properly implemented in India at the moment. That is the reason why though our testing numbers are low, but if you look at the number of tests done and the positives, I think we are still low compared to other countries.
Yes, Harry, I agree with you. So I think it's about less than 5% positivity at the moment.
Okay. So the next two questions also refer to India. Can coronavirus become an endemic problem in India? And why incidence curve linear in India? When will it flatten? I think the case in India is not that many, right? It's still less than 4,000 cases in view of such a big population.
Yeah, but the last 1 week, I think we are seeing rise in number of cases. Maybe the testing also is increased for the last 1 week. Some time will tell us, like next 2 weeks is very crucial, I think, whether to say whether this becomes more endemic here or not.
Okay. So yes, we all need some time to see the curve, whether it will become flattened or not.
I have a question. Are there still a lot of people in the street?
No.
No,
Yeah.
very few people. Yeah,
No.
it's very good.
The lockdown is very strong. Yeah.
Yeah.
But people in India wear the mask.
Yes, I think that is also being very strongly recommended. So I think what is happening in India is that the Prime Minister himself is coming every 4 or 5 days on TV and encouraging the common measures. Even in our state, our chief minister comes on TV almost every third day to encourage the common principles. So I think the lockdown is very strong. Of course, there are some areas where if there is some complacency, I think the government is taking appropriate steps. So if you ask me, I think it's more than 95% success to the lockdown at the moment. And yes, the use of mask is quite high. As Hari also mentioned, the WhatsApp is, the social media is helping so much in terms of communication that I think most of the people are aware of the use of mask and for social distancing and the importance of lockdown.
Yeah, from my experience in Wuhan, at the beginning of the February, I see there's nobody maybe in the street.
Mm-hmm.
So I just talked to my colleagues, said that maybe the new cases won't increase within 2 weeks. It's turned out to be true. So
Yeah.
why I ask you if there's so many people in the street or not? Yes, it's lockdown is very, very important. It's lessons from Wuhan.
Yes, absolutely. Absolutely.
Yeah.
So I think the world is aware of the benefits of lockdown and how Wuhan benefited from it. And I think that is an example which I think most of the world is following.
So the next question will be regarding to this epidemic shift or drift. Is there any evidence when disease transmit from one county or one country to another, and then there's some genetic shift leading to change in the virulence of the virus? So now people are talking about there might be two different strains. One strain is highly virulent, causing high mortality, while the other is a milder form. Is there any evidence suggesting this kind of hypothesis?
No.
Dr. Luo, do you see any different strains of, no?
No, I don't have an idea about this question. Okay, sorry.
No.
No.
Well, if that's the case, I think that maybe just we need some time to see whether or not. I think in the newspaper there was a case of 2 strains in Iceland a few days ago talking about. Now today they're talking about this coronavirus, COVID-19 in a tiger, and in Hong Kong there were cases of dog or cat being test positive. I guess if the virus can affect different kinds of mammals, it might happen eventually. There might be some antigenic shift or drift. However, this kind of change may not necessarily means the virus becomes more virulent, or and the change in antigen may not help its transmission in humans. So we just need more time to figure this out.
Dr. Bing Lam,
Yes.
can I go back to the issue of masks, the use of masks in public places? It seems to be that, practice differs from one country to another. And then I don't know about the latest recommendation. Does everybody need to wear a mask in public places? even though he or she is well, you know, in some countries recommend that you only need to wear a mask if you're unwell. You know, if you're well, you don't have any cough, you know, and any other symptom, you don't have to wear a mask. So what's the latest recommendation now? Does everybody need to wear a mask in public places?
Yeah, I think even in CDC, they're talking about in public areas, people should have their mouth and nose covered, not necessarily wear a mask. Mask should be left to healthcare providers, to doctors and nurses. Yes,
Even
everybody.
though they are symptomatic, asymptomatic.
Symptomatic, because there are 25 to 30% of patients may be symptomatic in the beginning, and by then they can already spread the virus. So therefore, they should have their mouth or nose covered with anything, not necessarily a mask. Mask should be left for
Everyone.
Yes.
Everyone
Yes.
in public places.
Yes. Public area. Yeah. That's
Yeah.
what CDC recommend, and they are not using the term mask, but then just necessarily means something should be used to cover the mouth to prevent transmission. Yes.
Okay.
May I ask? Oh, sorry.
Yes, sure.
Yes. With regards to the genetic shift, we have patients like those who are young and with no comorbids, but they have a more severe and critical cases. But and we also have patients who are elderly and they have many comorbids like a hypertensive, diabetic, but they have a milder course of the disease. So is there a way to know if we have like different strains already of the coronavirus?
I guess the presentation of the disease, the clinical symptoms based on a few things. Number one is the viral load. How huge is the viral load? Number two is the immune response. Many of the time for young people, they may die from the cytokine storm rather than the viremia. And number three is, of course, the presence of comorbidity. I guess in the young, many of the time, either they have a very big viral load to start with, or significant cytokine storm leading to the morbidity and mortality. Dr. Luo, and Dr. Lin said, what is your opinion regarding this issue?
I don't have did not have children in our hospital when I stay in Wuhan, but I have a female patient. She had grandchildren for fever just for 1 day and then recovered. I think most of the young patients recovered soon, and we don't know what happened for the patient. But the patient died in our hospital, most of them older than 60 years old. So I think the age is it's a very important factor for the patient who survive from the disease. Yeah.
Okay. Dr. Lin, do you have any other?
Yeah. I think because all my patients are adult patients, and I don't have any information about the children death due to the COVID-19. So the reports that there were some children have died in the US. I don't know why. Then I don't think it's an evidence to bring that this will be a mutation further in the US. We need more evidence.
It's true that we don't have the information about the children who died from this COVID-19 in Wuhan. I never have this kind of information about.
Yeah.
Yes, I don't listen to this news and who reported that the children died from the COVID-19 in Wuhan. Never.
Yeah.
Prof. Luo, in your presentation, you show us the CT images of patients COVID-19. Now, they do. It seems to me that my understanding is they do develop some fibrosis in the lung. So, what happens to this patient long term? Do they get significant lung fibrosis long term, like post-TB fibrosis?
So sometimes in the very late stage, there's a fibrosis for the patient, but don't worry about it. The patient will recover from the fibrosis after maybe 1 or 2 months. They will recover. I think because the regeneration of the lung is the capillaries is very strong. So I have one patient who was 37 years old, very critical, and 1 month later, and the CT scan improved, and right now improved a lot compared with the when he discharged from hospital. So it's
4 months. I mean, longer than 4 months. Are we still not? Are we still confident that they don't develop significant lung fibrosis beyond 4 months?
Yeah, I think the patient will recover. It's different from the SARS because the patient from the SARS fibrosis is very obvious. But in COVID-19, the patient recovered, though it's very slow in very critical patient.
You don't think it's too early at this stage to say that they won't develop significant fibrosis?
Because after several weeks, it's still improved. I think the patient feel very better and better. So the patient only have 38% of post-oxygen saturation. After the treatment, he can walk around. Yeah. So I don't think it's fibrosis is very important for this kind of patient COVID-19.
Good to hear that.
I agree with the opinion from the Dr. Luo. Yes, I have followed about 20 patients, and I found that it will take about 1 to 2 months to recover from the fibrosis. So the fibrosis is not really important. Sure.
Yeah. Don't worry about it.
Yeah. It's quite different from H7N9. Yep.
Well, that is good to hear that they don't develop long-term sequelae.
We have several cases with very critical and recovered and can take care of themselves. Yeah.
Yes, we have followed more than 100 cases with the lung function. It seems more than about 50% of the cases were for diffusion decline. One diffusion decline, but not so severe, about 50%.
Dr. Chajian, maybe you can proceed.
Okay, sure. So we now move on to the lot of questions, and I think there is this discussion about the role of using anticoagulation. Is there are anticoagulants routinely used for all the patients in the ICU?
Yes, if the D-dimer increase significantly, we use the anticoagulants for the patient. But be careful, some patients get the bleeding in stomach, and I think I take part in the discussion about one patient for the hemorrhage in the brain. So be careful.
So how to choose? The question is, how should the clinician decide, whom to give anticoagulation and whom not to give anticoagulation? Any tips and recommendations for that?
I think it should based on first the D-dimer, and second is that the risk for the DVT, and it's very important. I think, yeah.
What's your opinion, Dr. San?
Okay, I can share my experience. Maybe I can change this question. Would you use any anticoagulants in the ICU patients? I gave all the patients anticoagulants if they do not have any contraindications for the of the LMWH. Yeah.
Yeah, I agree with the doctor in them. Yeah, because the patient maybe use the sedation for them, low movement for them, so it's very important for them to prevent the DVT.
Excellent. So the next question is about inhaled steroids for asthmatics during pandemic. I think it's very clear. I think we get a lot of phone calls from patients that they are on inhaled steroids, and they have seen a lot of discussion on WhatsApp that steroids may be harmful for patients with COVID. So I think the message we are giving very clearly is that all the asthma patients should safely continue to use the inhaled corticosteroids. That is extremely important. On the other hand, it is important, and we encourage them not to miss their dose of inhaled corticosteroids and the inhalers which they're taking. I think the panel agrees on that. Does anybody have any special comment on that?
No.
Yeah, if not, no, we move on to the next question. The next question is, what is the best treatment protocol for those who are severely affected and need ventilation and intubation? Anything different? I mean, I think this question is coming from the point not maintaining well on the oxygen therapy, then whether we should what is the best treatment protocol once they get more severe on the ventilator.
I think that in my opinion, the most important thing is do the lung protective strategy. However, the based on the observation from the front line in Wuhan, we think that the COVID-19, I think that the ARDS due to the COVID-19 is not a typical ARDS. It's not a typical ARDS. The patients in my ICU, they always have the very worst compliance, and the PaCO2 is very high, always above 70, even above 80, and the recruitability of the lung is very bad. So the lung recruitment is not useful. However, the prone position is very good. There are 16 beds in my ICU. It means that 60 critical ARDS patients in my ICU, and I turned all the patients to prone.
To prone position.
Yeah,
okay.
yeah, prone position is
so
good.
I think that agreement is deep. Prone ventilation is good. I think these are the protocols where I think everybody is having an agreement upon, and I think your experience from Wuhan is also very useful for the audience. One question also which also comes up often is the role of NIV or CPAP, particularly as there is shortage of ventilators. Should this be encouraged, discouraged if you're in a difficult situation with ventilators, with the risk of spreading infection? What are the recommendations? What are the suggestions?
My suggestion, my experience is that use the non-invasive ventilation with a large dosage of steroid, just like what I mentioned before. Maybe 125 milligram twice daily to 250 milligrams twice daily. But just several days, for example, 3 days, no more than 1 week. Yeah, it's very important in a short time. Some patients recovered. I have 2 patients with very, very critical condition recovered from this treatment with non-invasive ventilation with the large dosage of the steroid. As said in the pathology changes, there's inflammation over there. And also sometimes we see the CT scan, and it's very likely in tissue lung disease sometimes. So also some vascularitis in the lung. So I think steroid maybe can be used. But sometimes maybe some doctors say that the steroid maybe inhibit the clearance of the virus, and sometimes we said that there are side effects of the steroid. But we just use it in a very short time, and not so high, just like in what we used in the SARS. The SARS, maybe we used the totally dosage maybe 6,000 milligram totally. But in my experience in 13 patients, we just use maybe no more than 2,000 milligram in total.
Yeah. So if I understand correctly, I think if you're using an IV, then there might be a potential role for steroids in those cases. Any other? I think this is an important question about the CPAP and the BiPAP in India, because the people are worldwide seeing the shortness of ventilators are there. Anybody on the panel would like to comment further on that, please? Anybody has more experience with NIV? Any recommendations, something to be careful of? Yeah, and if you're using NIV, are there any tips to make sure that there is no dissemination of infection?
In my opinion, the NIV is very dangerous in this pandemic. Yes, I agree that NIV is very effective in some patients. However, if the patient got a strong effort of breathing, MRV may be very dangerous, and maybe it will delay the intubation. So if the PF ratio of the patient is below the 150, I will intubate the patient as soon as possible.
Okay, great. And then this. Sorry, yes.
Yes, I would like to add something that there's another choice option that maybe use the high flow nasal cannula for this kind of patients for oxygen therapy. For the NIP, it is require a lot of care for the patients when they receive the NIP, but it's high flow is I think is less care for the medical workers. So it may be an option if the medical care works is shortage.
Okay. So have you used it? Do you have experience with that? Have you used it?
Yes.
Okay.
Yes.
Okay. Excellent.
Based on our data, it's helpful for some for the compared to the just simple or oxygen therapy, the nasal oxygen therapy.
And I think a last question I would have on this point is, what about splitting ventilators if the ventilators are short? Did you need to do that in China? Splitting ventilators, that is a discussion which is coming up. One ventilator for more than one person.
No, we don't use this kind of treatment.
These are the questions which have come up because you see a lot of discussion about.
Yeah, I know that there's in maybe Washington over there, they have 4 patients for one machine, shared machine, 4 patients.
Yes.
There are 2 respirators there for them. Yes. I just listen from this kind of information.
Okay. Good. So we move on to the next one. When COVID-19 patient turns bad, do we still treat them as conventional cases, or only intubate when they can sustain on high flow, etc., or we can intubate them earlier? I think this question is already, discussed. So we move on to the next question. There's a question about the role of neutrophil to lymphocyte ratio. Is there any role in prognostication on this? Any comments from the panelists, please? That if the lymphocytes are falling down, does it to say it's a worse prognosis?
Yes, I think a lot of paper have confirmed this.
Okay, this has been confirmed. Okay, we move on to the next one. Now this, there's a negative trial about lopinavir and ritonavir. So the question which has been correctly asked is, what is the role of lopinavir and ritonavir with the current experience and the current limited data available?
In fact, in the paper, they said that if you use this medicine earlier, in the early stage, maybe benefit for the patient.
Okay.
If you use in a late stage, maybe no use. Yeah.
Okay. So good. So I think the message that comes out is that if lopinavir ritonavir combination is to be used, it has to be used earlier on. Now the question will be: do we use it along with if you have a choice of hydroxychloroquine or lopinavir ritonavir, which one would you choose?
Chloroquine.
Chloroquine.
Yeah.
You choose chloroquine. Okay. So good. So I think experienced answers and clear answers for the audience. A role of hydroxychloroquine in treatment: should asymptomatic and mild cases also receive it?
Yes.
That means if you've even in asymptomatic, even for asymptomatic, because I think as Dr. Shiyue Li has mentioned that the conversion is quicker, to the swab negativity is earlier. So I think for asymptomatic and mild cases also they should receive it. That means asymptomatic means the contact of the patients, the positive patients who've been detected. So does the panel agree on this, that asymptomatic patients should get hydroxychloroquine as well?
Yes.
And I think this is the last question on my list: the role of IL-6 levels assessment and tocilizumab. I think this has also been very well covered. The question I would like to ask is that should all patients who are in the ICU and have high IL-6 receive tocilizumab? Or is that limited for only selective patients who are progressive?
In fact, we don't have did not have this medicine in our hospital, so I just discussed this with the other physicians and evaluated this antibody for the treatment of the patient. They said that in the critical condition may be useful for the patient, especially in the IL-6 increase significantly.
In any other countries which have experience with this, in Thailand, Malaysia, Philippines, or any other parts of China, Hong Kong, any experience about this?
May I make a comment, please?
Please, yes.
So we have one patient that received this medicine. And actually, what we found is that the patient has so far we have around 20 respiratory failure ARDS, but this patient has the shortest duration of mechanical ventilation, so he recovered sooner than other patients. So basically, but that's only one patient that we have. So we have some medicine for a few more patients, but we are making the protocol based upon the study from the hemophagocytic patients that receive this kind of medicine for cytokine storm. But that's only one patient that we have experience with this.
Yeah. Dr. Bing Lam, what about Hong Kong?
Well, I guess COVID-19 patients in Hong Kong are being recruited into different kinds of drug trials. And up to this particular moment, there's still no conclusion at the moment. I think it is very difficult to able to get to the conclusion faster, because what should be the correct endpoint we are looking at? Shall we look at how soon will the fever subside? Or shall we look at the viral load? Or shall we look at how many patients will proceed to severe form of diseases? But there is a personal factor there, the initial viral load, and how soon will their immune system respond. No matter what kind of randomized study you do, you cannot consider all these factors into the randomization. Therefore, whatever conclusion we may get from small-scale study may not be the truth. Because this disease, even without treatment, majority of the patient will survive and control the virus by the immune system. So it is not easy to have a crystal clear answer for these kind of drug trials.
No, I think that's very well, conveyed, Dr. Bing Lam. I think that's very important for the audience to know that we're talking about all these treatments for the selected number of few patients who would be in the ICU. Of course, if you have a large number of population suffering, you can have a reasonable amount of people in the ICU. So I think that's end of my discussion. And now we move on to the last part of the discussion, which Dr. Bing Lam will take over.
Yes, we have just a few more questions.
Mm-hmm.
And may I have those? Dr. Chajen, maybe you should close the PowerPoint file first, otherwise my file cannot be shown. Dr. Chajet?
Okay.
Yes, good, thank you. No, this is from the previous, okay. Discussion 4, right? Should be discussion 4. Sorry. Not discussion 2. The first question is, has any doctor encountered patients with autoimmune problems? Do they behave differently when they encounter COVID-19? Dr. Luo, Dr. Li, have you ever encountered a patient with autoimmune disease when they had this COVID-19? Did they perform differently compared to other people, other patients?
I just have one patient with RA, and after we used the steroid for the patient recovered. I only have one patient for the RA. Yeah.
Okay. So
yes, for this.
Yes, any other comment from the panel? Proceed to the next question. And I think we have discussed this question because Dr. Jamadou asked this previously. What about the role of face mask?
Yeah.
So we will just skip this question. How long an asymptomatic COVID-19 carrier remains infectious to others? Well, I guess that depends on how soon this autoimmune system will handle the virus. But as long as the period may even more than 1 week or 10 days, right? Dr. Law, any comment on what the longest period the patient can?
Yeah, I have one female, 27, and the test for the virus lasts for maybe 3 weeks. We give the interferon injection. After that, turn to negative. So sometimes it's difficult to say how long, but you should test the virus first.
Yes, to look for the live virus, right? Not only the nucleic acid, because that may last for weeks, even after cure. Yeah, okay. So the next question will be, is that antibody following natural COVID-19 is protective, and for how long? I guess from Professor Li Shiyue's talk, there's a study talking about convalescent serum to treat patients, severe patient. I guess that is protective, otherwise it will not be effective. But how long will this antibody last? Do anyone know the answer to this?
We don't have the answer because it's just in a short time.
Yeah.
But I think the Professor Chen Rongchang said that the antibody for SARS patient last year, they're still in a very low level. They can detect the antibody for the SARS even after 70 years. Yeah.
Good. So hopefully these two viruses are pretty close. So that yes. Good. Yes. Oh, we do have other questions for the internet, but then because we are over time, right? So probably we will close at this moment. And thank you all for joining this webinar. And thanks to Broncos. Good evening, and hope all of you keep health and safe so we can have webinar or other issues later.
Okay.
Thank you.
Thank you.
Bye.
Bye.
Bye bye.
Bye.